Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to express my deep thanks for Israel's committee for this kind invitation. I will talk about lens-induced secondary glaucomas that can be broadly divided into open angle or angle closure glaucoma. The open angle may be phacolytic, phacoantigenic, phacotraumatic, or lens particle induced glaucoma, and angle closure, which include phacomorphic, phacotopic, and glaucoma due to subluxation or dislocation of the lens. The mechanism of this pathology of glaucoma mostly due to papillary block, obstruction of the theca meshwork, inflammatory mechanisms, mechanical angle closure, pigment dispersion, and secondary open angle glaucoma. Let's go to lens-induced glaucomas that related to phacolytic glaucoma that's covered in 1955 by Flocks, that associated with hypermaturity of the cataract, and it is a secondary type of glaucoma characterized by the high molecular weight of the lens protein that block the trabecular meshwork. So if we have an aqueous sample, we find that there is a dense high molecular weight proteins that represent up to 35% of the total aqueous protein in phacolytic patients. By gonioscopy, it is actually difficult, but the angle is opened. You can judge it by anterior segment OST or UPM. Also, there is lens particles from the capsule. It is a dotted white flakes with macrophages that engulfing these high molecular weight proteins. There is a reduction of the vision. There is pain, marked elevation of the IOP with marked photophobia, hypermaturity of the cataract with cells and flare. The differential diagnosis is the acute angle closure glaucoma, neovascular glaucoma, lens particle, phacomorphic, and uveitic glaucomas. Actually, in these cases, the main line of treatment is to go on with the lens. You control the IOP with systemic or topical medications, use cycloplegic for 1 or 2 or 3 days, then anti-inflammatory drugs, and go on for surgery, either by cataract surgery or even manual small surgical procedures. Second type is the lens particle glaucoma, and this is very common. It is a very common type of glaucoma that we can see it with the small particles of lens that be hidden behind the periphery of the iris, especially in the sulcus and above the areas of between surface back of the iris and capsule back to the capsular axis. There is low grade of increased intraocular pressure. It is associated actually with gradual increase of the intraocular pressure. Sometimes the dislocation of the submarine ring, actually we didn't see it more anyway, but with, as I said, with a small small segment or fragments of the lens that we can't see it during the surgery, can make this prolonged low grade inflammation. Clinically, we can found the recent ocular surgery by the patient, his history with AC inflammation, elevated intraocular pressure, and injected with localized or diffuse corneal edema. Gonioscopy, mostly we can't judge about these small fragments that be present, and by direct obstruction of the ocular meshwork with these lens fragments, treatment actually also surgery with IA if you can see these lens particles. And as you see in these figures, many lens particles in AC. The problem is actually with the hidden particles behind the iris. Third type is phacoantigenic or phacoanaphylactic glaucoma. In the past, it was named lens-induced uveitis or phacoanaphylaxis, discovered since 1922. It is a granulomatous immune reaction against exposed lens proteins, and because this disorder is more frequently associated with hypotony than elevation of the ocular pressure, the term lens-induced uveitis is again most appropriate than to be as a glaucoma. Exclusion of the type of anaphylaxis is also appropriate, as IgE and basophils and mast cells, the cells of allergy or immune antigen antibody reaction, mostly not so much in these cases. So phacoantigenic is a rare entity characterized by concentric layers of polymorph nuclear leukocytes, lymphocytes, epithelial cells, and multinucleated giant cells by studying the pathology of the lens. These are known as also zonal granuloma. The pathogenesis actually including lens capsule disruption, considered as an autoimmune response, as I said, with severe uveitis and secondary glaucoma. Patient, if it's not diagnosed early, have a pain, red eye, elevated ocular pressure, granulomatous KPs with strial hypopyon NAC. IOP is most commonly low until later if there is a pathology, either sclerosing pupillae, pupillar block, or dense peripheral anterior synechiae that leads to increase in ocular pressure. So we can interfere by management of the reaction by corticosteroid, controlling IOP, and removal of the lens matter. And sometimes we need to do pars plana vitrectomy. The ectopial lens or associated glaucoma, it is involved with the subluxation or dislocation of the crystalline lens and may be associated with acute, intermittent, or chronic elevation of the intraocular pressure. Subluxation of the lens implies a partial dehiscence of the venules, but dislocation will be lost and sometimes in the vitreous. And clinically, you can judge through the iris by iridodenesis or irido or phycodenesis. The lens may be dislocated, as I said, in the vitreous. The causes may be trauma and some syndromes like Marfan syndrome, Weil-Marchesani syndrome, or homocystinuria. In these types, there is a mechanism of pupillar block is common with peripheral anterior synechiae and maybe vitreous prolapse leading to increased intraocular pressure. So the management is lens extraction or removal with anterior vitrectomy if it is needed. Phacomorphic glaucoma, I think Professor Ala Zawawi will discuss it more briefly. And phacomorphic glaucoma actually in the management, as I said, but I would like to hint about ALPI, argon laser peripheral iridoplasty, sometimes helpful in these cases. So this is a summary of lens-induced glaucoma. Is either phacomorphic, phacolytic, phacoantigenic, or due to lens particle. The major second part in this lecture is the glaucoma related to intraocular lens implants. This include pupillary block by IOL. In these cases, we can find aphakia with vitreous block, sulcus fixated IOL, anterior chamber IOLs, and secondary IOL implantation. The mechanism is block of aqueous passage from posterior to anterior chamber. Signs is iris Pompei and shallow anterior chamber. Treatment is actually maybe just YAG laser peripheral iridotomy or surgical peripheral iridotomy and surgical correction if persistence of the pupil is of the IOL to be in its place. And this is a surgical pupillar block. Sometimes we can see it with a normal lens, but actually we talk about the intraocular lens as in the right photo. UGH syndrome, I think it is a little bit rare, but if you put a single piece IOL in the sulcus, you should follow up your patient actually with high concentration, because you can see the uveitis, glaucoma, and recurrent hyphema. So if you found it, you should interfere surgically by replacing or repositioning of the intraocular lens. Sometimes we can see it with the iris fixation IOL. So most of cases now we have the PC iris fixation IOL. Pigment dispersion also we can find it with the IOL if there is multiple frictions. There is pigment liberation, trapezial blockage. Risk factors including sulcus placement of the single piece IOL. The 3-piece IOL, we can use it when you have rupture of the posterior capsule with disintegrated IOL. The management actually also to interfere with the management of reduction of IOP and IOL repositioning or exchange. Actually, because I have a routine examination with the gonioscopy, I saw many cases with this pigment dispersion glaucoma. Glaucoma associated with IOL dislocation. This is mostly intermittent with pupillar block and angle crowding with chronic inflammation. Clinical features sometimes in the back dislocation or subluxation or anterior displacement IOL. The treatment is surgical repositioning and exchange or removal of IOL. Sometimes we will see it actually more with trauma. Vitreous block and secondary glaucoma due to anterior vitreous face obstructs the aqueous flow. Risk factors is posterior capsule rupture, aphakia, complicated cataract surgery, and mostly we can do YAG hyalodotomy and anterior vitrectomy. And we can see with the anterior segment OCT, we can see actually the aqueous or water or fluid trapped behind the IOL. Capsular Brooks syndrome is due to accumulation of the fluid behind the IOL, myopic shift with elevated intraocular and distended capsular bag. The treatment is also nodmiamiag capsulotomy. Summaries ring glaucoma, I discussed it before. Ghost cell glaucoma, rarely to see it due to degenerated erythrocyte obstructed the trabecular meshwork. And the management actually is medical. Sometimes we need to do vitrectomy in such cases. In the summary, we have a differential diagnosis between the phacolytic lens particle, phacoantigenic ectopia lentis, IOL pupillary block, UGH, pigment dispersion, and ghost cell glaucoma, either regarding the angle and the mechanism of glaucoma. Take-home messages is lens-induced glaucomas are highly or largely secondary glaucomas with identifiable mechanisms. Phacolytic lens particle and the phacoantigenic glaucomas are the principal inflammatory lens-induced glaucomas. Ectopia lentis commonly causes glaucoma through pupillary block. The important IOL-related causes are pupillary block glaucoma, UGH syndrome, IOL dislocation, big dispersion, capsular block syndrome. Definitive management usually requires correction of the underlying cause regarding to the lens or intraocular lens, and any abnormality in addition to, of course, the IOP control, either medical or surgical. Thank you again for my invitation. Thank you.
Dr. Mohammed, thank you very, very much. And we take this opportunity that you finished early. So, okay. Okay. Dr. Mohammed, you finished early, so we would like to we would like to get benefit from this 1 minute and ask you one simple question, please. Yes. We've excellently demonstrated the glaucoma that may be related to the intraocular lenses.
Yes.
What about your experience with piggyback IOLs? Because they are being increasingly used for nanophthalmic eyes, for example, and the lensectomy after the EAGLE study. Sometimes the biometry necessitates a piggyback IOL. So how about the glaucoma, that potential glaucoma from the two IOLs being placed in the posterior chamber? What's your talk about that?
Yes, a very good question. From my opinion, Dr. Nader, if we have this piggyback IOL actually inside the capsule, if it is inside, controlled well inside the capsule, I think there is no problem. But most of cases, as you said, is anophthalmic or microphthalmic eyes. We should take care very well regarding to the IOP. Either through making surgical peripheral iodectomy to help or to avoid any block from the pupillary block. Okay. And of course, if I have the chance, to did argon laser peripheral iridoplasty or SLT or even ALT, argon laser trabeculoplasty, I have a good experience in these situations, and they all of them did so well for controlling of IOP.
Okay. Would you recommend against using the two IOLs, the piggyback? Would you recommend, for example, for a nanophthalmic eye to use the maximum power available single IOL and do with glasses the rest? Do we
this one of the options. Okay. If I have two IOLs, I should make my I prepare the eye for avoid any risk of increased IOP. As I said, either with peripheral iodectomy, ALP, okay, or even argon laser trabeculoplasty or SLT. Great. And they do very well.
Really?
All of this, I combine ALT with ALP or SLT with ALP. And in these cases, when I put the second IOL, I make also the surgical peripheral iodectomy at the same session.
Excellent. Thank you.
ممكن أعلق؟
Please.
عايز أعلق.
اتفضل.
أنا بشتغل بيجي باك. بس عمر ما حصل لي سكندري جلوكوما.
عشان كده
ليه؟ علشان اللانس ذات نفسها في النانوفثالميك اي 5 مللي.
يس.
والانتيريور شامبر نورمال. المشكله كلها جايه في البوستيريور سيجمنت. البوستيريور سيجمنت هو اللي شورت، انما الانتيريور سيجمنت في النانوفثالميك اي هو نورمال. ولازم تحط واحده في الباج وواحده في السالكس. ممنوع تحط الاثنين في السالكس. لو في الباج قصدي. لو حطيت الاثنين في الباج هيحصل انترلينتيكولار فابريزيا.
يس.
ودي مأساة.
صح.
يعني
between two faces of the IOLs.
مأساة.
مم.
فلازم تتحط واحدة في الباج وواحدة في السالكس، ما بيحصلش حاجة، ما بيحصلش جلوكوما، لأن المسافة دي اوريدي كبيرة.
Yeah.
غير لأن النانو ثالمكس باي ديفينيشن الانتيريور سيجمنت بتلاقيه معقول، لكن البوستيريور بارت هي اللي شورت. ف
sometimes دكتور علاء
انا ما لجأتش ابدا ان انا اعمل
I,
لا
I,
peripheral
I,
iridotomy ولا
I
جلوكوما
fully
surgery.
agree with دكتور علاء. وده يعني my experience over the last 20 years.
بالظبط.
I'm doing maybe like about 20-25 cases of piggyback IOL with non-ophthalmic eye with glaucoma surgery. Sometimes I do glaucoma surgery in these patients also, but I put one IOL in the bag, the single piece.
لازم one IOL
The
in bag
three
والتانية
piece
في
I put it
السالكس.
in the sulcus.
بالظبط كده.
Sometimes I capture it, sometimes I don't. And I never had a problem with AC turbulence in these
اوعى
patients.
تحطهم الاثنين في الباج والا هيحصل انترلينتيكال
interface
paresthesia،
interface
وده
yes.
مأساة
Yes.
مأساة كبرى يعني.
yes.
Thank you. دكتور مؤمن بليز.
انا كنت بتكلم بقى يا دكتور علاء برضو بان انا اعمل نفسي بروفلاكسس. لو انا قدام مني تشانس ان انا اعمل سيرجيكال بريفرال ايريكتومي وانا شغال، هيبقى مور يعني كبروفلاكس. الدكتور طارق نفسه بيعمل سيرجري during الاوبريشن نفسها.
أنا عندي برضو my own experience some experience في موضوع النانو ثالميك ايز. مش عارف صوتي مسموع ولا
مسموع.
المشكله ان انا قابلت some cases of malignant glaucoma post these cases early في my life يعني. فانا من ساعتها started ان انا I should do in all the cases of nanophthalmic eyes iridectomy وزونيولوتومي او anterior hyalodotomy وكور يعني anterior vitrectomy.
كورفيتريكتومي.
بصراحه
Okay.
مع ده بيقلل very low incidence او never ان انا شفت بعد كده one case of malignant glaucoma
مع اللينزكتومي.
مع اللينزكتومي. وانا بصراحه I am preferring ان انا اوردر لينس single
هاي باور.
single lens with high power يعني available بس 60 و 65. اتفضل دكتور علاء بيه.
لا راجع نفسك في القصة دي تاني. السنجل السفيريكال ابيريشنز بتاعتها مرعبة، فالتو احسن في السفيريكال كواليتي اوف فيجن. راجع نفسك تاني في القصة دي.
يمكن احنا بس بنبص لنقطة تانية، احنا مش عايزين نخش في جلوكوما بس حضرتك استاذنا بقى. فالريفراكتيف الريزلتس مع حضرتك ريفراكتيف ليه تبقى احسن اكيد.